Hello, good evening, all. My name is Jordan Mayberry, and I am a physician assistant that practices at a hepatology clinic here in Dallas, Texas at UT Southwestern. Thank you all for joining me this evening after what I assume is a long clinic day for most. But we have some exciting information to share about MASH and the treatment of MASH. So we'll get started. We have an hour here together to talk a little bit about MASH and a lot to cover. So here are our disclosures. So this is the group that put this talk together. So here are some of the objectives that we have for the evening. We want to assess the epidemiology of MASLD in MASH. We will discuss the assessment of an individual who has MASLD or MASH, from inflammation to fibrosis, and then we'll talk a little bit about the extrahepatic comorbidities that can be associated with MASH. And then we will try to understand the current best practices for managing the patient with MASLD or MASH. Here is our accreditation. We will get to have some CME hours after this talk. And here are some tips on how to claim that CME credit. All right, so let's get started today. We're going to start this evening talking a little bit about a patient, and we're going to keep this patient, Mrs. AP, in mind throughout our entire talk this evening. She's a pretty typical patient that we would see in our liver clinic. She is a 52-year-old Hispanic female. She has a BMI of 35. Her past medical history includes hypertension, dyslipidemia. She does have type 2 diabetes, and with that BMI of 35, she does have a diagnosis of obesity. She was previously on atorvastatin, but this was discontinued by her PCP because of those elevated liver enzymes. She's also on lisinopril and semaglutide. We do a physical exam and we can palpate that liver edge, so she does have some hepatomegaly. She has a family history of cirrhosis. Her mother passed away from cirrhosis, and her father died of cardiovascular disease. Currently, she drinks 1 to 2 drinks per week, no drugs, no tobacco, but has a very sedentary lifestyle. We start the workup for Mrs. AP, and this is what we find on initial lab test. Her ALT and AST are mildly elevated at 84 and 76. When we look at the synthetic function, how is the liver doing its jobs? We look at things like her bilirubin and her albumin. Fortunately, those are within normal range. And then immediately my eyes are going to go to her platelets. Her platelets, fortunately, are 219. But what we know, the first signs of portal hypertension due to cirrhosis is thrombocytopenia. So platelets are always one of the first labs that I look at when we are evaluating these patients to see if we have concern for cirrhosis. We fortunately already completed that chronic liver disease workup. It's important that we rule out any other autoimmune or genetic liver diseases. So we did a full autoimmune workup. We looked for ceruloplasmin to rule out Wilson's disease. Fortunately, she was negative for any autoimmune or genetic liver diseases, and her viral hepatitis panel was also negative. For those of you who have been in practice for a little while, you may know that we previously referred to steatotic liver disease as NASH or NAFLD. There recently was a consensus that got together in 2023 and made a decision to change that nomenclature. We felt it was important to highlight that steatotic disease is often related to metabolic dysfunction associated steatotic liver disease. So, to really highlight the metabolic dysfunction that is associated with this liver disease. So, NASH is now MASH, And NAFLD is now MASLD. And that's really what we will be covering throughout most of our talk today. It's important to remember, though, that there are other steatotic liver diseases. There are other diseases that can cause steatosis to be deposited within the liver tissue. There is now a new and separate category for our patients that have cardiometabolic risk factors and increased alcohol intake. That is our MET-ALD. Of course, alcohol-associated liver disease can cause steatosis, and then there can be some other rare genetic liver diseases like Wilson's disease. We also have to think about things like drug injury whenever we see steatosis within the liver. So one important takeaway is the new nomenclature, but also making sure that we are distinguishing between pure MASLD and our MET-ALD patients. How do we diagnose MASLD? Well, often these patients are coming to us, maybe even for something else. Maybe they have right upper quadrant pain, or you're just getting routine labs in internal medicine or primary care, and we see mild elevation in the liver enzymes. So we make a decision to get some imaging of the abdomen. So often steatosis is diagnosed or identified on imaging. Occasionally, we can identify it on biopsy, but I would say most of the time we are identifying the steatosis on imaging. So once we have evidence of steatosis within the liver, we ask ourselves, does this patient meet any of the cardiometabolic criteria? And you can see here on the right-hand side of the slide what that criteria is. The patient has to have 1 out of 5 of this criteria: elevated BMI, an elevated fasting glucose, or has to be pre-diabetic or have type 2 diabetes, hypertension, or changes in their cholesterol levels. We also want to make sure, like I mentioned before, that we are evaluating patients for their alcohol intake. So if a patient has one of these cardiometabolic risk factors, we have to make sure we're not getting too narrow-minded, and we have to ask ourselves, are there any other possible causes of steatosis? Mainly, could this patient also have MET-ALD? So if the patient is not drinking alcohol in excess, they have steatosis on imaging, and they have one of these cardiometabolic risk factors, we would diagnose them with MASLD. If they do not have any of these cardiometabolic risk factors, we really are thinking about something else in our differential. Is this related to medication? We might have to do a liver biopsy in this situation to really understand what's going on within the liver tissue. But today, we'll just be covering that diagnosis of MASLD. MASLD is a current and growing problem in both the United States and around the world. You can see here at this pooled data from NHANES that it shows that the overall global prevalence of MASLD is 30%. But shockingly and interestingly, if we break this data down a little bit further, what we saw is that globally, the prevalence of MASLD in 1990 was 17%. And then if you look at the prevalence of MASLD between 2016 and 2019, that prevalence rose to 38%. So this is a huge growing problem, not only in the United States, but all over the world, and really requires some urgent treatment and education to providers about how to treat MASLD. I will highlight here that the highest rates or the highest prevalence of MASLD are in our Latin American countries. So keep that in mind when we are evaluating our Latino patients, much like Mrs. AP, who we are discussing this evening. So back to the United States. It is estimated that we have close to 38% of our population that has steatotic liver disease. And of that 38% of patients, 32% of those patients have MASLD. So a large majority of patients that have steatotic liver disease in the United States have MASLD. These numbers are alarming because if we estimate that about 100 million Americans have MASLD, 9% of those patients have already developed advanced fibrosis. So we're talking about 9 million Americans with advanced fibrosis. That is similar to the population of New York City. So that is a lot of Americans that have already developed significant fibrosis. And then when you add in patients that also have MASLD, that just increases the number of patients that are already advanced fibrosis from steatotic liver disease. Steatotic liver disease is just one part of the metabolic syndrome. So when we have a patient in front of us that has MASLD, it is very important, again, that we don't get too focused and that we are making sure that we are assessing these patients for other comorbidities. We should be assessing for hypertension, for dyslipidemia, for cardiovascular disease. We should be evaluating for obstructive sleep apnea, making sure that we are checking hemoglobin A1Cs for type 2 diabetes. And then there is a strong correlation between our patients that have PCOS and are postmenopausal and having MASLD. So we want to make sure that we are really looking at these patients as a whole and we're not just getting too focused on the liver itself. Patients with MASLD have a very high risk of developing other metabolic diseases. 50 to 90% of patients with MASLD have an elevated BMI. 50 to 70% of patients with MASLD have type 2 diabetes. 69% of this patient population has cardiovascular disease, and half of them will have hypertension. MASLD is just seen as the liver manifestation of metabolic syndrome. There is a very strong interrelationship between type 2 diabetes and MASLDs. We know that diabetes promotes increased risk of steatohepatitis, increased risk of cirrhosis, and increased risk of hepatocellular carcinoma. MASLD itself promotes insulin resistance, so we have increased risk of dyslipidemia. And unfortunately, in our patients with MASLD and type 2 diabetes, their type 2 diabetes tends to be more difficult to manage. And they also have increased risk of cardiovascular disease. Let's talk a little bit about the natural history of MASLD. So as you can see here, we kind of move through the natural history in this liver. So on the left-hand side, we have a nice healthy liver, which then has a steatosis deposited into the liver tissue. So you have steatotic liver disease. Once you develop steatosis and that steatosis begins to cause inflammation, that inflammation over time leads to fibrosis. Only 15 to 20% of patients will progress from stage 1 fibrosis to decompensated cirrhosis. And it's estimated that it takes about 24 years to progress from stage 1 fibrosis to decompensated cirrhosis. So you might think, okay, 24 years, that's a decent amount of time in the lifespan of our patients. But In our clinic, we are diagnosing patients with MASLD younger and younger. I have patients at the age of 18 and 20 that have evidence of MASLD with fibrosis. So if we estimate that it's going to take them 20 years to move to decompensated cirrhosis, it's possible that these patients will have decompensation or need for liver transplant in their early 40s. And then once we develop decompensated cirrhosis, we are at an increased risk of liver cancer. Every 100 out of 100 patients that have decompensated cirrhosis, 2 patients a year will develop liver cancer. MASLD and MASH have a huge impact in our society today. MASH has become the #1 cause of cirrhosis in adults. It is the #1 indication for listing for liver transplant in patients with HCC. It's the #2 leading cause for patients on the wait list for liver transplantation. And it's the #1 cause for patients on the wait list for liver transplantation among our Asian, Hispanic, and non-Hispanic white females. So now that we understand how we diagnose MASH and we have a better understanding of the natural history of MASH and some of the possible complications that we can expect if our patients are going to progress, let's go back to Mrs. AP. And what are the next steps for a patient like Mrs. AP who has metabolic syndrome and steatotic liver disease? First, we want to make sure that we get her restarted on that atorvastatin. Next, we want to stage her liver disease. We want to make sure that we are looking at her as a whole patient, that we're looking at the full picture and assessing for systemic comorbidities. And then we want to establish a plan for managing liver disease in the context of multidisciplinary care. Historically, MASH has been diagnosed by liver biopsy. Fortunately, we now have several non-invasive tests that can distinguish between our low-risk MASH patients and our at-risk MASH patients. The reason that it's important to distinguish between these two categories is because our lower risk MASH patients, so those are patients that have steatosis alone or very early stage MASH, they can focus on weight management and optimizing metabolic syndrome with their primary care providers. Our patients that are at risk MASH, who possibly have more fibrosis within the liver tissue, should be identified, and we should focus on a more liver specific treatment for those patients. So, what are some ways that we can stage liver disease? The first NIT or non-invasive test that we will talk about is the FIB-4 test. The FIB-4 is great. It's a great place to start because it's easy. You need a CBC and you need some liver enzymes. So we need the ALT, AST, platelets, and then the patient's age. This is a calculator that you can Google online. You can do on your phone in your MedCalc app. Some EMRs even have a dot phrase. So I know that our Epic system just has a dot phrase. So I can say dot fib4 and it will calculate the fib4 for me. The way that we use the fib4 is the cutoff for low cutoff is 1.3. So if a patient has a FIB-4 of 1.3 or lower, they're a very low risk for fibrosis within the liver. If they have a higher cutoff of 2.67, then we worry about fibrosis. They have a higher probability of stage 3 or stage 4 fibrosis within the liver. FIB4 is very good at predicting outcomes. So what this particular study showed is that this dark gray line here at the top of the graph shows that if at baseline you had a higher FIB4 score, then you also had a higher incidence of adverse liver outcomes. It also showed with the dotted line here, the darker dotted line, if your FIB4 increases over time. So a FIB4 was calculated at baseline and then calculated again in 12 months. And if your FIB4 increased over time, that also showed that you had poorer liver outcomes. So higher baseline, FIB4 shows bad outcomes, and then increasing FIB4s shows bad outcome. So FIB4 is a good way for us to not only check a baseline fibrosis, but it's something that we can use to determine progression of liver disease as well. The second non-invasive test that we'll discuss today is the ELF score. This is a proprietary blood test. It uses several markers to estimate fibrosis within the liver. This is a blood test that you can order at Quest or LabCorp. And the way that this test gives us information is it tells us about whether the patient is at risk for early fibrosis, concern for moderate, presence of advanced fibrosis, or if this person has risk for cirrhosis. So it gives us a range of a score. And you can see here on the right-hand side with the dotted line or the dot graph that it correlates very well compared to biopsy. ELF is also very good at predicting outcomes. So what this shows us is that in patients that had an increase or a higher ELF at baseline, this was associated with progression to cirrhosis. And then also patients that had worsening of their ELF score, this is also correlated with progression to cirrhosis. So we talked a little bit about two blood tests that we can use for non-invasive testing to determine fibrosis in the liver. Let's talk a little bit about an imaging modality that we can use to assess fibrosis in the liver. This is transient elastography. There are several different kinds. The kind that we have within our clinic, it's called the FibroScan, and that's probably the one that's used most widely in the United States. It measures liver stiffness over an area estimated to be 100 times greater than that of a liver biopsy. Some of the pitfalls to ultrasound elastography or to transient elastography is that BMI can affect the reading. So with a higher BMI, it can be difficult to get a good quality exam. And then we can also see overestimation of fibrosis if there's underlying hepatitis, if there's congestion within the liver, or if there is a mass present within the liver. We get two different measurements with transient elastography. We get the CAP score, which correlates with the fat content within the liver. And then we get a fibrosis score, which is reported in kilopascals. Much like the FIB4 test and the ELF test, transient elastography is very good at predicting outcomes. So what these two graphs show us here on the right-hand side, this is the fibrosis score. And we can see here in the blue, the patients that have higher fibrosis score have significantly lower or poorer survival rates. We also see that patients that have fattier livers, so the patients that have higher CAP scores here in the gold, also have poorer survival. MR elastography is another imaging modality that can be used to assess fibrosis within the liver. It can be much more difficult to access the MR elastography. I am fortunate that I work at a academic center where we do have access to MR elastography, but I know that out in the community, it can be a little bit more difficult to find imaging centers that have this modality. And I will say that here recently, I have been getting much more pushback for coverage for MRI elastography. Previously, it was pretty easy to get insurance companies to pay for MRI elastography, but just within the last week or so, I've had to do 3 or 4 peer-to-peers to try to get these MRI elastographies covered. So I am seeing less, or I'm just seeing more pushback recently. And what it shows is similar to that of the transient elastography. In patients that have higher kilopascals, there's higher risk for liver transplantation and death. And then it's important for us to clarify, though, that the kilopascals in MRI elastography are not the same as the kilopascals in the FibroScan. So it's making sure that we are reading these tests appropriately. So we'll go back to Mrs. AP. So we have completed the chronic liver disease workup and we have determined that she has MASLD. So the next step is for us to assess her fibrosis. So we start with a FIB-4 score. Her FIB-4 score was 2.1. So she falls into that intermediate category. So that still leaves us kind of questioning, well, how much fibrosis does Mrs. AP have? Some of the limitations of the FIB-4 score, there's a really large indeterminate range. So from 1.3 to 2.6, so a large range of indeterminate fibrosis. This test is less accurate in elderly individuals. We have to remember that age is part of the numerator in this particular test. So the test is going to be higher in patients that have that are older. So the cutoff, or what is considered elderly in the FIB-4 world, that's going to be 65. So if a patient is 65, we move that cutoff from 1.3, that low cutoff from 1.3 to 2.0. Now that's not the case in our with Mrs. AP today, but it is something important that we should remember in our patient population, especially if we are calculating FIB-4 in our patients that are 65 or older. So we can't give her a fibrosis stage based on the FIB-4 today. So what we recommend is, what should we do next? We are going to get an ELF score for Mrs. AP. Her ELF score was 9.3. So based on her ELF score, she would have moderate fibrosis. But she is pretty close to that cutoff that would move her into advanced fibrosis. So how I would educate my patient in this particular stage, in this particular situation, is I would educate around the diagnosis of MASH, and I would say that she likely has stage 2 to 3 fibrosis based on her ELF score. We want to make sure that we are not misdiagnosing these patients or underdiagnosing the fibrosis within these patients. So the 2 to 3 range, make sure that we cover the amount of fibrosis that could be possible within the liver. So is this sufficient information, or do we want more data about the amount of fibrosis within the liver? Anytime I have these indeterminate tests, I want to get as many non-invasive tests as I possibly can just to have more reassurance about how much fibrosis is present within the liver. Fortunately, we have a fibroscan within our clinic, and so we are able to get Mrs. AP in for a fibroscan. Her fibroscan showed that she had an elevated CAP score at 340. That is that diagnosis grade 3 steatosis, and her fibrosis score was 10.1. So she has stage 3 fibrosis on FibroScan. So based on her ELF score and her FibroScan score, we would diagnose Mrs. AP with MASH with stage 2 to 3 fibrosis. Now, if we wanted to get more information or if we were possibly concerned about something else going on in the liver tissue, maybe drug injury, we could either consider an MRE for more fibrosis assessment. And in some cases, we may even consider a liver biopsy in these patients. But for Mrs. AP, we are pretty content with this diagnosis of MASH stage 2 to 3 fibrosis. So what do we do next now that we have a diagnosis? How should we manage patients that have MASH with fibrosis? So some of our management goals are to improve disease activity and resolve the steatohepatitis. So we want to decrease inflammation within the liver because we know that inflammation over time is what leads to more fibrosis. So we're trying to prevent progression, right? By decreasing that inflammation, we're preventing disease progression. If we can prevent progression, the next best thing would just be for us to actually see regression in the fibrosis that is already present. So if we could achieve fibrosis regression. We also want to make sure that we are addressing all coexisting metabolic conditions, and we want to manage extrahepatic manifestations. How do we reach those goals? So some of the treatment options are diet, physical activity. There are medications that can be used, and we can consider bariatric procedures, both endoscopic and surgery. We have to remember that achieving these goals, achieving these management goals, takes a multidisciplinary team. So what do the guidelines say about diet? Well, most importantly, we want to try to lose weight, right? So depending on how much fibrosis is present, that each of the societies have different recommendations about the percentage of body weight that these patients should try to lose. But overall, the recommendation is that these patients should lose anywhere from 5 to 10% of their current body weight. The Mediterranean diet is the overall recommended diet for this patient population. And we should be trying to increase physical activity. This should really be structured and tailored to the patient. And there is some data that coffee is associated with less advanced liver disease. So there is some recommendation that coffee consumption is likely beneficial to these patients. So overall, the data shows us that weight loss works, and that weight loss really does help patients with MASLD and MASH. Now, the issue, as most of us know, I personally know after having a baby 6 months ago, weight loss is hard. It is very, very difficult to do. So what the data shows us that if patients are able to lose 3% of their current body weight, we can see steatosis improve by 45 to 100%. If you can increase that weight loss to 5%, ballooning and inflammation will improve by 41 to 100%. If you can increase that even a little bit further to 7%, we can see actual MASH resolution in 64 to 90%. And then if we can reach that 10% weight loss goal, 45% of that fibrosis within the liver will improve. So there is data showing that weight loss helps with MASH. But in 261 patients that were counseled on weight loss, only 18% of those patients were able to lose 7% of their body weight, and only 10% of those patients were able to lose 10% of body weight and sustain that weight loss over a year. So it's very difficult to lose weight. What are the recommendations around physical activity? We really need to be tailoring this to our patients. The overall goal is to aim for 150 minutes of moderate intensity or 75 minutes of vigorous intensity over the week. Now, the way that I educate patients is to start small and be consistent and then ramp up from there. I think all of us could make improvements in physical activity, whether it's taking a walk during our lunchtime, whether it's waking up a couple of minutes earlier to walk around the block before we head out in the morning. There can be small changes that we can all make to increase our physical activity. So start small, start today, be consistent, and then continue to ramp up that physical activity. Beyond just lifestyle modifications, we know that there are some medications that are available for weight loss. We also have endoscopic procedures for weight loss, such as the gastric balloon or the gastric sleeve. And then we could also consider surgery like gastric bypass. Now, it's important to remember that none of these strategies, so none of the medications and none of the endoscopic or surgical indications are approved for MASH treatment. They are used to help with weight loss, which we know in turn improves MASH. What is the current guidance on medications for MASH? So the AASLD released guidance in 2023 around medications for MASH. Semaglutide can be considered for its approved indications. So we can consider semaglutide if the patient has type 2 diabetes or obesity, because we know that there is a cardiovascular benefit and it likely improves MASH. Pioglitazone also improves MASH, and it can be considered in the context of type 2 diabetes. There is not enough data around semaglutide, pioglitazone, or vitamin E to demonstrate an anti-fibrotic benefit in our patients with cirrhosis. So these medications are not well studied in our cirrhotic patients. But we do know for sure that medications like metformin, ursodiol, statins should not be used in treatment for MASH because they do not offer a meaningful benefit in histologic improvement. So really, how should we be using these medications in patients that have MASH? The best way to think about this is to optimize cardiometabolic risk with these medications. So if patients have MASH and also have type 2 diabetes, we can consider the use of the GLP-1s and the co-agonists like tirzepatide to treat their diabetes because it likely improves and helps with MASH. Some of the SGLT2 inhibitors can also be an option for the treatment of type 2 diabetes. Metformin and insulin can be considered as well. We should be using statins in our patients that have dyslipidemia. Statins can be used in patients with MASH and can be used in patients with MASH and fibrosis. And then if patients have obesity, we should be considering the GLP-1s or the co-agonist for the treatment of their obesity. And we can consider bariatric interventions for the treatment of obesity. Where we need to be careful about bariatric interventions are patients that have underlying cirrhosis, as they have increased risk of complications from surgery. The use of vitamin E is controversial. In 2023, ASLD said that vitamin E can be used in select individuals that do not have diabetes. EASL gives a little bit different guidance. EASL says there is a lack of robust data that shows that vitamin E has significant efficacy in MASH, and there are some long-term risk for patients that also have diabetes and are on vitamin E. So the EASL guidelines do not recommend vitamin E as MASH targeted therapy. When we take a look at bariatric surgery for patients with obesity, so in this particular patient population, there was liver biopsies done prior to bariatric surgery. And when we compare the patients that underwent bariatric surgery to the patients that were non-surgical controls, our patients that underwent surgery had fewer poor liver outcomes and also had less cardiovascular events compared to those that did not undergo surgery. Okay, so we talked a little bit about what we can currently do for treatment for our patients with MASH. Let's go back specifically to Mrs. AP. So we want to make sure that we educate these patients well on lifestyle modifications, including weight loss, medications, and exercise and diet. And exercise and diet are acceptable for our patients that have early stage disease, so F1 fibrosis. But in our patients with moderate fibrosis, we see that we need to increase or we need additional measures to help halt or reverse the fibrosis that um, is already starting to take place in these patients. And for that patient population, we do have a new medication. Resmetirom is the first approved drug specifically for MASH. It is an oral partial agonist of the thyroid hormone receptor beta. It was approved in March for patients with NASH with moderate to advanced fibrosis in conjunction with diet and exercise. I know it's a little bit confusing that some of these slides still have the word NASH, even though the nomenclature has changed. If the clinical trials were done or started before the nomenclature change took place, then we still use NASH in these clinical trials. So in a lot of these graphs and things, you may still see the word NASH, and that's the reason why. So the first study was the Maestro study. It is an ongoing phase 3 randomized controlled trial of resmetirom in our patients with NASH with liver fibrosis. So we looked at 2 different doses of the resmetirom compared to placebo. There were 2 primary endpoints at week 52. So the goal was to see complete NASH resolution with reduction in the NASH score by 2 points with no worsening of fibrosis, as well as improvement in fibrosis with no worsening of NASH. So we want to see improvement of inflammation with no worsening of fibrosis, and we also want to see improvement in fibrosis with no worsening of inflammation. The study overall had 966 patients enrolled. A majority of the patients had F3 fibrosis. A lot of them had type 2 diabetes, hypertension, dyslipidemia. Statins could be used in this clinical trial, and GLP-1 agonists could also be used in this clinical trial. So what did we see? In our patients that were on the 100 milligrams of the resmetirom, we saw that 29%, almost 30% of patients saw NASH resolution with no worsening of fibrosis, and 25% saw fibrosis improvement with no worsening of their NAFLD activity score. And we also saw a decrease in their overall LDL at week 24. The most common side effects that we see with the resmetirom are diarrhea and nausea, but overall a fairly tolerable medication. So now that we have a new medication that has been approved specifically for the treatment of MASH, who should we be considering to start on this new therapy? It is not recommended that we use this medication in any patients that have cirrhosis. There are ongoing clinical trials for patients with cirrhosis, but this medication is not currently approved to be used in our patients with cirrhosis. If they have active liver disease, so another underlying liver disease such as viral hepatitis or autoimmune hepatitis, this would not be a good candidate for resmetirom. If they have excess alcohol use or active thyroid disease. So the patient population that we want to consider for the use of resmetirom are our patients that have MASH with that stage 2 to 3 fibrosis. How should we monitor for safety and efficacy in these patients? At baseline, we want to make sure that we're getting a hepatic function panel, a thyroid function panel. We could also check a lipid profile. We must have some sort of non-invasive test that measures liver stiffness to confirm that this patient has stage 2 to 3 fibrosis. We want to check the hepatic function at 3, 6, and 12 months. So every 3 months, we're getting hepatic function on this patient. We can check thyroid function at 6 and 12 months, and also include that lipid profile at 6 and 12 months. And then 1 year out, we can consider repeating that non-invasive test to see if there's been any improvement in the fibrosis score. How should we assess treatment efficacy in these patients? Is our patient responding to the resmetirom, and should we continue these patients on resmetirom? So once we initiate treatment at 12 weeks, we would make a determination. Is there any worsening of their fibrosis, or is there a consistent increase of ALT? If so, we would stop the resmetirom. If we see an improvement on their fibrosis based on FibroScan, or normalization or complete improvement of ALT, that shows that there is some beneficial response of the resmetirom, and we should continue. If there's only a minor reduction in the fibrosis score on the FibroScan or no real improvement in the ALT, then we may want to reevaluate our strategy at that time. And I just want to highlight that we do want to continue to monitor for safety with blood work every 3 months. So how are we going to manage Miss AP now that we have all of the information about her fibrosis score? We've done education on lifestyle modification. So we counseled on education and Mediterranean diet. She is currently on lisinopril for her hypertension, and we restarted her atorvastatin for her lipid control, and she's on semaglutide for her type 2 diabetes. So we are controlling those comorbidities well. From a liver's perspective, her targeted liver treatment, we would start her on resmetirom. What should her follow-up look like? We talked a little bit about that treatment guideline and how we should be following our patients on resmetirom. So I would recommend that we're getting blood work every 3 months, and then we should reassess her fibrosis score 12 months after initiation to see how she's improved and if she's improved and if we should continue treatment. There are a lot of MASH therapies on the horizon. Resmetirom is being studied in cirrhosis. It's in phase 3 clinical trials for our patients with F4 or cirrhosis. Semaglutide is also in phase 3 clinical trials for the treatment of MASH. And you can see that there are several medications in in phase 2 and phase 3 clinical trials. So very exciting time for the treatment of MASH and for our patients that we can have more options for the treatment of MASH. So in summary, MASLD and MASH and its complications are growing. We know that this is a huge issue, not only here in the United States, but a global issue that we are facing. Non-invasive tests can be used to identify at-risk patients. A multidisciplinary management is critical for this patient population. Lifestyle interventions for all, so diet and exercise interventions for all of our patients with MASLD and MASH. Resmetirom for qualifying patients or our patients with stage 2 to 3 fibrosis. And then we may even consider bariatric procedures for those that meet criteria. It's important that we treat the patient as a whole and make sure that we are medically managing all of the comorbidities, so type 2 diabetes, the obesity, and the cardiovascular disease. Resmetirom is the first FDA-approved treatment for non-cirrhotic MASH patients who are at risk for adverse outcomes, so those stage 2 to 3 patients. And we had those guidelines that we went over, so it's important that we follow those recommended algorithms for assessing on treatment safety and treatment response.